I want to start my topic with two cases, slightly different but same degree of metabolic acidosis. These are recent patients I took care of. First case is a 40-year-old man with a history of PSC, complicated by cholangiocarcinoma. Had a liver transplant last year for that, and on immunosuppressive medicine. And post-transplant, he had allograft giant cell hepatitis. In early February, he underwent the rituximab in addition to immunosuppressive medication. Then he developed some constitutional symptoms that is not feeling well. In the mid part of February, he felt more sick. He went to his local doctor. Each time he went, his blood pressure was a bit on the lower side. He kept getting lots of fluids, and then furosemide was started because he started to accumulate fluids. And then mid-February, he was found to have bloodstream positive for ESBL or E. coli and the strep group A. In early March, his serum creatinine concentration rose from 0.8, his baseline, to 2.3. At that time, he decided to fly to Rochester because he was transplanted liver. He received liver transplant with our center. So during 8-hour flight, he had a very minimal urine output. And just as a reference, he went from Anchorage, his home, flew to Rochester, and today I present this case and all the way from the US to here. So he's been traveled a long way. So when he comes to clinic, he has multi-organ failure, bacteremia, metabolic derangement of encephalopathy, acute kidney failure, and new onset of atrial fibrillation, severely immunocompromised with a tremendous volume overload. And if you're looking at his admission situation, he's very acidemic. 7.26 is while he's receiving bicarb. His serum bicarb is at 8 single digits. Lots of base X. PCO2 was 17. And his urine studies show high-grade ATN. So that's a case of a young guy, immunosuppressed, severe septic shock and lactic acidosis in that kind of setting of AKI. Second case is a few days apart from the first case, elderly gentleman who has pancytopenia due to aplastic anemia, immunosuppressed, tremendously immunosuppressed, also baseline cancer, who had rip-rolling acute respiratory failure, ARDS, due to Pseudomonas aeruginosa pneumonia. So in this patient, on admission, he's again receiving bicarbonate, blood pH is 7.18, PCO2 was 48, but rapidly progressed to 60 and 50 and 60. He had to be proned and to recycle using special bed to try to get respiratory oxygenation, some ventilation. So tremendous amount of respiratory failure, acidosis, and acute kidney failure. So these are the treatment, lots of respiratory treatment, try to get him to ventilate, but he has no lactic acidosis. He has not developed the lactic acid. So two patient case. One is lactic acidosis, liver abscess, and the second case is pneumonia, Pseudomonas pneumonia, and no lactic acidosis. Both of them has volume overload, acute kidney injury. So you wanted to start CVVH, but would you do 22 bicarb or high bicarb in these two cases? So with that, I want to briefly look at the acidosis, different type of acidosis. In passing, I'll talk about the potassium effects, pathogenesis, mechanism of a proton generation, proton generation in relation to cellular behavior, cellular sodium and calcium, and the CRRT options. I have no financial disclosure. So in terms of acidosis in critical care patients, we cannot leave them alone because regardless of what kind of acidosis, the proton excess lowers vascular tone, depresses cardiac contractility, and increased incidence of arrhythmia. And by the way, both of my cases has new onset of arrhythmia. But the issue with bicarb to neutralize those protons is a really controversy. There's some studies showing potential harm, mainly if you give bicarb and you coupled with sodium, cause volume overload, and bicarb is a precursor of CO2, you could cause worsening CO2 retention. So there's always this dilemma. But both of these negative effects, as alluded by my previous speakers, that could be minimized by CRRT, in my center mostly CVVH. So if you're looking at the acidosis effects, there's really multiple effects. And these are the studies done in non-lactic acidosis situation. But it's also applied to acidosis related to the AKI. For instance, acidosis immediately induces a negative nitrogen balance. It's proportional to the amount of acid excess and starting from day one. So if the patient's in AKI with a low bicarb for a week, he could have a tremendous amount of insulin resistance. He could have a tremendous amount of muscle catabolism, decreased albumin synthesis, in addition to hemodynamic effects. And these are quite nicely studied in adult human patients. So even in acute AKI, acidosis should not be ignored. And if you're looking at CVVH, this is a recent study in a cohort of AKI patients with electrolytes alteration and requiring CVVH. At the beginning of CRRT, about over 60% of a patient has one electrolyte mineral deficiency, 67 has at least one excess. So these deficiency excess is very common when you start in a patient with AKI and critically ill requiring CRRT. And if you're looking at the deficiency, normal, excess, at the time 0 of a CRRT versus time 24 hours after CRRT, mostly CVVH. And you can see the black normal part of sodium can be normalized, calcium can be normalized, potassium can be normalized, phosphorus can be normalized. So most of the time, CVVH does work in the correcting electrolytes. The good part, unique aspects of CVVH, I really don't have to say much, is to bring the volume under control and bring the mineral under control, not in a zigzag way, but it's a very smooth, gradual, tolerable situation. But with acid-base, again, there were quite a few recent studies showing even in patients with severe respiratory compensation, even respiratory failure with respiratory acidosis, they tolerate bicarb of 32 without generating worsening PCO2. This is a difference between CVVH and intermittent dialysis. For instance, in this study, the patients with pre-CVVH PCO2 greater than 40, 52.7 after 4 days of CVVH went up to 53.4. So there's no net PCO2 retention. So in the patient with respiratory failure, they could tolerate the high bicarbonate in renal replacement therapy. This is a most recent comprehensive review looking at CVVH correcting acid-base and electrolytes. And these points of limiting downtime, you wanted to mitigate profound pathophysiology, underlying pathophysiology, and these were all well-known principles. But if you get down to the acidemia, for instance, our patient has a lactic acidosis and respiratory acidosis. These come down to the recommendation is in the setting of AKI, CRRT technique are useful in treating uncontrolled acidemia. So it's really not giving you the granularity of what to do. If you're looking at the last year's study, this is a Mayo study. It's a retrospective cohort, historical study looking at CVVH patient on the in the duration of 2016 and 2006, 2009. All AKI patients require CVVH, and they also did a propensity score match the cohort. So all things are being equal. What happens if you start patients on 22 bicarb CVVH versus 32 bicarb CVVH? And these are their cohort. If you're looking at the mortality, in-hospital mortality and 9 months mortality, 90-day mortality, and you can see the high bicarb group did poorly. 32 bicarb group patients had a lower survival versus 22 bicarb CVVH has much better survival in both full cohort and propensity matched cohort. So if you're looking at these data further, most of the patients are critically ill unit patients with anion gap and lactic acidosis. But this study is not differentiate lactic acidosis versus non-lactic acidosis, but most of the patient does have lactic acidosis. So the conclusion from this study is that high bicarbonate bath in CVVH might be deleterious for patients with acute critically ill and AKI. But let me show you another study. This is a prospective randomized interventional study, except it's done in pig, not in human. And this is a 12 pig induced the AKI, and they induce respiratory failure. pH is acidemic, and these pig has clear acidosis, respiratory acidosis, and they divided it into 40 bicarbonate, high bicarb CVVH versus 20 bicarb CVVH, and prospectively follow along this pig. And these there is no PCO2 retention, and this pig has absolutely no lactic acidosis and mostly respiratory situation. And what happened to the results? Following up to 12 hours, the high bicarb group survives much better than the low bicarb group. So it's, you know, if you're looking at, although the study is different, one is human, one is pig, and methodological could be very different. The pig study is small, but randomized interventional. Human study is cohort match. They're quite different. But what about the difference in the type of acidosis? So you can pretty much say this group is lactic acidosis. They seems to respond better in a little bit of signal of response better with 22 bicarb versus respiratory failure. They respond very nicely with high bicarbonate. I think it'd be worthwhile to looking into the type of acidosis. So you have respiratory acidosis, mineral acidosis versus lactic acidosis. And at the cellular level, they are quite different. One is intracellular proton generation, proton exchange for calcium, for sodium, intracellular sodium increases. And the other one is respiratory mineral, renal failure, usually mostly predominantly extracellular. So there is really no motivation for the proton from intracellular space goes out of the cell in exchange the sodium. So intracellular sodium in that kind of acidosis is really on the lower side instead of a high side. Here, if you do CVVH and you take off protons from the circulation, extracellular space, actually you trigger this proton-sodium exchange, and you could exacerbate intracellular sodium elevation, which could activate the sodium-calcium exchange, causing intracellular calcium to increase, and actually you can trigger cell death, inflammatory response, and as well as apoptosis. But on the other hand, these acidosis is very different, mostly extracellular. If you remove those cells or neutralize those protons, you essentially return the system into a normal state. This is analogous to the potassium effects in the setting of different acidosis. In the lactic acidosis, mostly intracellular sodium increases, which causes activation of this pump. Actually, more potassium will get into the cell. And in patients with lactic acidosis, most of the time, you don't have associated hyperkalemia for patients who, for normal adults doing strenuous exercise. We never have to worry about their potassium because lactic acidosis does not cause potassium to shift out of the cell. On the other hand, if it's a hyperchloremic acidosis, if you give patient with 0.9% saline, and this is extracellular or the other non-lactic acidosis, and you cause this opposite effects, and you could worsening cellular potassium, and that's the opposite effects of potassium responding to different type of acidosis. So in that kind of a case, lactic acidosis could ultimately cause the sodium to be up, and this process could be augmented if we oversaturate them with bicarbonate. Is there any other, you could argue maybe lactic acidosis, so you give a high concentration of proton, you could trigger more cellular death, and that might contribute to adverse effects. And do we have any analogous information to see if this is a real signal? One situation is the infant brain. So under normal situation, neonate's brain, the intracellular pH is slightly on the lower side. But those infants who has asphyxia usually have cellular lactic production. And when these infants with this kind of situation become more elevated in intracellular pH, which is mostly due to aggressive bicarb. If you give aggressive bicarb treatment, bicarb will neutralize protons. In the end, you have higher intracellular pH. And these neonates does much worse. If you kind of elevate their intracellular pH, which neutralize protons, and actually these have a much severely abnormal versus less treatment with bicarb and less pH. These are borne out with multiple rodent studies. If you're blocking this sodium proton exchange channel, sodium will not go in and calcium will not go in. And this is also demonstrated in the stroke model. If you knocking down the sodium proton exchanger, and you would essentially create much less brain injury than the normal kind of situation. So back to our patient, one with lactic acidosis, one with non-lactic acidosis. For that patient with lactic acidosis, we did the CVVH. In the 3 days, his weight went down from 82 to 60 something. His volume is optimized. he received the 22 bicarb, and we studied the Lasix. He regained kidney function, started to make urine. But so this is off CVVH. His bicarb is always 1920. He had no issue with the recovery. On the other hand, the second case, he had overwhelming infection and platelets down to single digits. And the family, we did 2 days of CVVH, but the family decided to withdraw case. So this is the summary. Essentially, CRRT is effectively correct acidosis and electrolytes alterations. However, correcting acidosis does not mean you corrected the underlying causes. For the second case with overwhelming infection, eventually he died. But it would be worthwhile to differentiate the type and underlying pathoetiology of acidosis, appreciate different type of acidosis could engender different cellular responses, just like a potassium. And for the lactic acidosis, you probably want signals telling us that we need to be careful with overly aggressive providing bicarb. However, we needed further more study. But with non-lactic acidosis, you neutralize the acid, essentially return the system to a normal range. So with that, thank you very much.